this is a topic which gynecologists deal with differently and a fetal medicine person deals with differently. So your agreeing to speak on this is going to really add value to all the gynecologists here. So I'm really honored and welcome to this platform.
Thank you so much, madam. So when you gave me this topic, I was thinking it's a huge topic to cover, and you wrote on predictors and diagnostic methods. So actually, the topic is very apt because predictors are different and diagnostic methods are different. So I will cover them as a fetal medicine, and maybe because I am an obstetrician, we will look at what standard of care by most guidelines are, so that we all are on the same page when we are managing these babies. So we all know that in 1642, this child was born, which was of a size of a quart mug, so 1.3 liters, and this survived and became Isaac Newton. But however, we don't have such Isaac Newtons being born so often, and a lot of them don't even grow to reach adulthood. So let us first look at the definitions for WHO. The definition is babies which are born prior to 37 weeks of gestation. But they have been categorized by WHO into extreme preterm, which are less than 28 weeks, very preterm, 28 to 32 weeks, and moderate to late preterm as 30 to 37 weeks. But we as obstetricians are used to calling babies as less than 34 weeks and more than 34 weeks as preterm. So these are early preterm and late preterms. And because our morbidity and our counseling is more dependent on whether the baby is less than 34 or more than 34, we kind of conveniently use this term, but WHO has different definitions for it. So I looked at literature, and about 15 million preterm babies are born each year worldwide. Of this, about 1 to 2 millions die every year. So the rate of preterm births is about 11%. India is a little more, is about 14%. That means of all the 10 babies that deliver, one of them is going to be preterm. And this has been increasing. You can see at 2020 and 25, it is still rising, and maybe because of multiple pregnancies and because of us doing iatrogenic deliveries. So that is a major problem also, that we are delivering preterm babies for our own non-medical indication. We'll talk about as it comes. So preterm is the largest direct cause of neonatal deaths. And this deaths, almost 50% of neonatal deaths are preterm, which could be either direct causes or it could be indirect, that the preterm baby has more chances of infection and so they die. So this is the largest single disease in the global burden of disease analysis. And your taking this topic up is very important because we deal with them so often. Almost 10% of all our pregnancies are preterm. So death is one side, the other is the survivors. So the survivors also, there's a huge amount of disability, cerebral palsy, visual and hearing disorders, as well as the economic cost both to the parents as well as to the country. So it's a big burden, which is highest in Africa and South Asia. So if you can see in this, the maximum is in South Asia and almost 60% in Africa and Asia. And the extreme preterms are less. It is the ones which are late preterms are more common. So we need to prevent those which are late preterms more. And we top lot of things in India, and for preterm births also, India tops the list by WHO 2018. And I got this article which says in our Times of India that every 1 in 4 children which are born premature across the globe is from India. So 1 in 4, that's a huge number, and India is on the top. So among the 27 million babies born each year, about 3.5 are born premature. And these babies not all survive. So there is a large survival gap. That means in countries like India, which is low income country, 90% less than 28 weeks will die. But in high income countries or in corporates where the facilities are better, 10% of these less than 28 weeks will die. So there's a large survival gap between the survivals of less than 28 weeks and more than 28 weeks. So we need to approach it. Our priority is prevention, the treatment of preterm, which is there isn't anything to treat preterm. We manage the preterm and the baby has to be also managed. So I'm going to take you through how do we try to prevent preterm births by finding out the risk as well as trying to find out the etiology for this. So 3/4 of preterm births are preventable, but the problem is that the cause is unidentified in 50% of cases. So it's a one syndrome with lot of etiologies. The etiology is vague and we don't know what finally causes preterm birth. So our textbooks used to give all these. We do a per speculum examination to see for infection. We do risk factor assessment. There's a home uterine monitoring, which was available. There's some salivary history that you can see or a fetal fibronectin. But all these fetal fibronectin, bacterial vaginosis, home uterine activity are not have any improvement in the outcome when we try preventing preterm because of these factors. So only things which are important are one, risk factors, second, cervical length, and maybe we could look at fetal fibronectin as a predictor for preterm birth. So when we understand identification of risk factors, the most common is a history of preterm birth because that increases the risk almost twofold. Some of them are modifiable, some are not modifiable. So adolescent or advanced maternal age, short interval distance, very thin or very obese patient, lifestyle with lot of stress and physical activity, smoking, alcohol. Family history of preterm again is a risk factor, which I used to think is not a cause, and ART itself is a risk factor for preterm. In the medical disorders, we have all these which we already know about, but things which I am more concerned about is if obstetric, there is placenta previa abruption or even a first trimester bleeding, that is threatened miscarriages in the first trimester are at high risk for preterm. Anyway, twins and polyhydramnios, uterine malformation, infections are all causes for preterm birth that we know of. Then a history of any cervical surgeries, conization, uterine instrumentation. And in this, it is not only the second trimester, it's the first trimester, multiple DNCs, hysteroscopies, which are at high risk. So those patients who are IVF conception have all gone through multiple abortions or have gone through hysteroscopies. So they become a high risk for preterm labor. And any cervical laceration during a delivery. This is all right if there's a tear, but cesarean section at full dilatation is also a risk factor. So if you had a DTA and you had a section, the risk for preterm increases. So these are those extra things which I thought we need to understand. So among all of them, the major risk factor is the history of a preterm birth and current pregnancy, short cervix. And these two things have to be looked at. So you look at risk factors for preterm history and a cervical length, which is a short. So it also depends on how early did this preterm occur and how many times that preterm birth occurred, because these two have a very high chance of recurrence. So when I am going to get a patient who comes to me for the first time, my history is very important. So I want to understand whether the preterm birth was spontaneous. That means the labor started on its own or had a PROM, which is in 75% of cases. But it could also be iatrogenic or medically indicated. We call them as provider-initiated preterm births. So this is if there is some fetal reason like an IUGR or a maternal reason like a PIH, there could be a cesarean section being done. So these are not spontaneous, but they are preterm. So WHO says a lot of these iatrogenic initiated preterm births are are without any indications, and that should be curtailed and should be looked at. So if you have a cesarean section for preeclampsia or IUGR, does it increase the risk of preterm? Yes, it still does increase the risk of spontaneous preterm. So the ACOG says that although it says don't do serial cervical length assessment, but it recommends reducing the risk by preterm improving the pre-pregnancy control of medical disorders, or do a good fetal surveillance, or start them on aspirin so that the risk of preeclampsia comes down. So there still is a risk, and if you take it, I think we should continue to monitor these babies with the cervical length assessment. So should we do a universal versus contingent screening? That means, do I do a cervical length assessment in all patients who come to my OPD, or do I do it only in patients where the risk factors are high? And the ISWAG says we need to do a cervical length assessment in a second trimester scan in all the patients. So whenever we are doing our anomaly scan, we need to assess the cervix length, and in case it looks short, we need to do a transvaginal ultrasound to see the cervix length, which is same as what ISWAG says. So why do we want to do universal? Is it is cost effective, that we know. It is preventable. And third is, if we miss this opportunity of assessing the cervix length, we will have a poor outcome. So we have got various methods to prevent it, and so it is better that we test it. So now the major part of how we do is our ultrasound assessment. So what cervical length will define that there are at associated risk for preterm birth. Earlier, we used to take 2 centimeters, but for all purposes, 2.5 centimeter or 25 millimeter is defined as short cervical length, whether transabdominal or transvaginal. But if you see the image on the right side, that's a transabdominal cervical length assessment, where internal and external loss is slightly not so defined, while in a transvaginal cervical length, in the left side of your image, you can see both the points very well defined. So a transvaginal cervical length is good, safe, reliable, patient acceptance also, reproducible also, and cost effective, because you're anyway doing an anomaly scan, you add on a transvaginal assessment. And this is better than our PV examination or a transabdominal assessment. So here you can see I brought in 3 images. One is with a completely empty bladder, one with partially filled bladder, and one with fully filled bladder for transabdominal assessment of cervix length. So one is the distance between the probe and the cervix is huge, so it may not be very well defined. Second is, there could be an artificial elongation of this uh, length of the cervix because of a full bladder. If it is empty, we can't see because there will be acoustic shadowing from the pubic symphysis or from the part of the fetus head also. So these are problems, and so the accuracy is not so good, and we may not be very good in assessing transabdominal cervix length. And so the best method is to do transvaginal. So here you can see in the first as well as in the second, there are 2 different patients, 2 different cervical length assessments that we are doing in here. This end, it has to be a transvaginal placement in the anterior fornix. And then you need to get a longitudinal axis orientation. That is, the cervix should be seen zoomed up, covering almost 75% of the screen. The bladder should be empty. Here you can see that bladder assessment is required, minimum amount of bladder, and then you look at the cervix. So the internal loss is measured, the external loss is defined, and you should not put in too much of pressure. How do you understand pressure is the thickness of both the lips of the cervix should be same. So you can see in both of them, the thickness, I have not pressed too much on the cervix length. And so the length, the thickness of both the sides of the cervix is same. So that means we've taken the length correctly. And you see this eco-dense line that we are seeing. And like in NT, we take an average of all of them, or the highest of all of them. In cervical length, we will take the shortest of the cervical length. And if there is a curvature, then that means it is already more than 2.5. But how do you measure it? Either you trace it, or you take it in two segments, one straight and then the other one, and add them all together. So that is how your cervical length is assessed. So here you see, when you're doing a cervical assessment, put some pressure to see whether the funnel increases or not increases. This is called as a dynamic shortening. So here in both of these, it looks like the cervix will funnel, but when you put on pressure, there is no more extension of this funneling. And so this is what we need to do some for a minute. You need to put in. Book says 5 minutes, but even a minute of, if you put in and you do some fundal pressure, the cervix will open up if it is funneled. So when it is funneled, you have to measure below the level of the funneling. So you can see the first one is completely T-shaped. We use this mnemonic of trust your vaginal ultrasound. Trust is T. T-shaped is normal. Then you have V, which is your Y, and then V. And then you have a U, which is completely distended. So T, Y, V, U is how you understand the funneling. And how you measure it? You have to measure it below the funnel, and you need to also measure the dilatation of the funneling that you have. The more the funneling, smaller the cervical length, more is the risk of preterm. I just got this video yesterday, which I was trying to understand whether this is a funnel or not. So beware of this myometrial contraction. The cervix length is good and it looks like a funnel, but there is a persistent myometrial contraction above that, which is not going. So you wait for some time, ask her to pass urine, bring her back after some time and reassess inside, because this is a normal cervix and not a myometrial contraction. What else do we look at when we do a cervical assessment is to look for this sludge. So earlier the ACOG used to say sludge is not important, but yes, this sludge is this ecogenic area in the cervical canal, which could be meconium or Burnix or clot or infection, and is high chance for additional risk for preterm labor. So when you look at that, you also look for this sludge and mention it in the report. Now I am going to take you through when you have a history of patient who has no history of preterm birth. One second.
Dr. Vanna, we can't hear your voice. You are muted. Yeah.
Now I'm better. Yeah.
Yeah. Now you
No,
open.
the headings were all below that, so I took it away. So now I'm trying to find out if once we found out the cervix is short or not short, how do we manage or prevent these? So should a woman with a current singleton pregnancy without a history of preterm birth be screened for risk of preterm? So ISWAG as well as ACOG says universal cervical length screening. When do we start it? They say 18 to 24 weeks, but maybe 16 earlier. But these are patients who have no risk factors. So maybe anomalies time 18 to 24 weeks is the right time to do a universal cervical screening assessment. And if we find transabdominally that it is short, then definitely we need to do a transvaginal, because the accuracy of TVS is much better than transabdominal, as I just spoke to you about. So now we have found out that the cervix is short in a patient who has no previous history. What do we do for them? So no previous preterm births, no history of risk of preterm, and I was evaluating and we found the cervix to be short. So one, we could start them on vaginal progesterone is recommended as a management option to reduce the risk of preterm. In these asymptomatic singleton pregnancy without a prior preterm and incidental finding of a short cervical length. And this length, as I said, is 25 millimeters. So this has come from this EPIC trial. This EPIC trial has come in 2021, which says that almost 44% there's decrease in the spontaneous preterm birth less than 34 weeks in patients with short cervix. And before that also, we had this optimum trial also for vaginal progesterone. So vaginal progesterone, there is no problem in recommendation to all patients with short cervix. So, but do we start them on Circlage or not? So the ACOG as well as ISWAG also are of the opinion that cervical Circlage should be considered. So ACOG says for women in otherwise low risk population, Circlage placement in women with cervical length less than 25 millimeter between 16 to 24 weeks has been associated with reduction. So that means they are also recommending starting Circlage in patients with short cervix. The ISWAG recommendation is that after we start progesterone, monitor the cervix length, and in 1 2 weeks, if the cervix length is shortening, then we put a Circlage inside. So both ways, what we do is we start progesterone for all these patients with short cervix, and in case in a week or two I find that the cervix is shortening, we put in a Circlage inside. The NICE also says the same thing, that you need to either do prophylactic vaginal progesterone if there is either a history or cervix length is small, but you could put a Circlage if there is a short cervix with a history. So don't want to confuse you all. This is the table which I follow also, and that is what is recommended by ISWAG also. Asymptomatic women, single measurement of cervical length by transvaginal ultrasound between 18 to 24 weeks in low risk asymptomatic patient. If the cervix length is more than 25, we put her into routine care, and whenever we do a scan, we just assess transabdominal cervix. But if it is less than 25 millimeter, progesterone is started vaginally up till 36 weeks. We follow a cervix after 1 2 weeks, up, and then maybe monitor till 24 weeks. If it shortens is they are giving it as less than 10, but I would think if it shortens, we put in a Circlage. So now I come to patients who had a prior spontaneous preterm birth. Here it is definite that all of them are offered progesterone supplementation, which can be started early. So we are not waiting for the ultrasound assessment and then starting progesterone. We are starting progesterone very early, and then we need to monitor them. So transvaginal ultrasound is indicated starting at 16 weeks here. Here 16 weeks because the risk of second trimester miscarriages and also start at 16 weeks. So they need to be monitored. So now again, do we start them on, put them on Circlage or not? If the cervix length is short, then we would offer a choice of both and tell them that probably cervix Circlage is also an additional procedure which should be done in these cases. So where you have a prior preterm delivery, offer a choice of either progesterone or a Circlage as a shared decision. So you need to tell them both things. The progesterone may help, but Circlage may also help. So depending on what the patient decides. So all of them, no evidence to support addition of an alternative progesterone. So if you are on vaginal progesterone, adding a prolyton or adding a dydrogesterone has no evidence. And second is switching from one method of progesterone to another method is also not beneficial in short cervix. So only thing beneficial is the patient who's already on progesterone and has a short cervix, we could put a Circlage placement. And the same thing the NICE also says, if there is a combination of history plus cervix length, then you can give a choice of either progesterone or Circlage or both of them. So this is the ACOG again, like the table I gave for asymptomatic, no history patient. This is for asymptomatic with a history of preterm birth. So if there has been a preterm birth between 14 to 27 weeks of gestation, you start the transvaginal ultrasound at 14 weeks before the previous preterm occurred. Or if it happened between 28 to 36 weeks, start the transvaginal ultrasound at 16 weeks. But in both of them, you would start them on vaginal progesterone from 16 weeks onwards. As I said, those who already have a history of preterm, they are at increased risk, and for them, progesterones need to be started to prevent preterm early. And then you do a transvaginal ultrasound. If the transvaginal ultrasound is more than 30 millimeter, nothing to be done, just monitor every two weekly till 24 weeks. If it remains the same till 24 weeks, they will usually not go into preterm. The ones where you have between 26 to 29, more than 25, but it's still less than 3 centimeter. You may monitor every week. Progesterone is anyway going on. But if the size is less than 25 millimeter, it is better to put a circlage. So I would think this is the gist for patients with previous history of preterm delivery. This is how we need to follow. And this is also the ACOG and the ISO guideline. So here you see this is a patient who had one missed abortion, one preterm, but this preterm was IUGR related preterm, and the baby died of cardiac anomaly. Then she had a painless abortion, leaking a day after anomaly scan. So next pregnancy, because of this history indicated preterm, we did put a circlage at 15 weeks. You can see the length of the cervix was beautiful after the circlage, but it continued to give her progesterone, monitored the growth of the baby. But in spite of a circlage, she had a preterm delivery at 32 weeks after steroid and Maxil. So probably the circlage has still worked because the previous one was at 20 weeks and this was salvageable at 32 weeks. Again, another first trimester abortion, one 16 weeks abortion, and then 120 weeks leaking. So this is very typical of incompetent cervix. So present pregnancy, you see, with the transabdominal, the length looks so huge, it looks good, but we still put in a circlage because she had a very typical history of second trimester abortion. After the circlage, you see at around 24 weeks, the cervical length had become very, very short, about less than 1 centimeter. And she came in labor at 24 weeks. A tocilizumab was given. We tried steroid Maxil. Our NICU saves 24 weeks. So we did a section, but finally had an intracranial bleed and did not survive. So here there could be an option of doing a rescue circlage for women between 16 to 26 weeks with a dilated and exposed unruptured fetal membranes. But patient has to be explained about the risks of the procedure as well as the likelihood of the baby surviving or having serious neonatal morbidity. So this is by the NICE guideline. So here we have a IVF conception, two missed abortion, first trimester, one ectopic, and then 19 weeks referred for ecogenic focus. Now here all of them were first trimester abortion and an ectopic. So there weren't any second trimester history. And she came for a scan to us for ecogenic focus. An incidental finding of this on a transabdominal ultrasound when you saw there was a U-shaped cervix and transvaginally also the membranes were bulging in the vagina, and immediately rescue circlage was done, but she leaked in 3 days time and delivered vaginally at 20 weeks. So even if there's no history of a second trimester abortions or a preterm delivery, these multiple first trimester abortions and IVF and hysteroscopies are significant history itself to say that yes, we need to assess the cervix very often. Do we do infection screening? Bacterial vaginosis associated with preterm, but there are not much studies to say that intervention helps. So for the purpose of prevention of preterm, screening for bacterial vaginosis is not recommended by the guidelines. In multiple pregnancies, again, we do assess the cervix. We do look at the same time between 18 to 24 weeks of gestation for our cervical length assessment, but there are not much studies to say whether cervical placement or progesterone supplementation reduces the risk of preterm birth in multiple pregnancies. So this will more depend on how you look at multiple pregnancies. So routine prophylactic use of vaginal progesterone or intramuscular 17-OHP to prevent preterm in twins is not recommended. Circlage is also not recommended, but we would still think that for multiple pregnancies, even if the data doesn't show efficacy, if I find a short cervix or a funnel cervix, we would put a circlage, and all these twin pregnancies are put on progesterones as part of the twin assessment. So a lot of controversy in multiple pregnancies, but if we are putting it for short cervix for singleton, we as well put it for short cervix in multiple pregnancies. Yes, the results may not be as good because of twins that we have. Here we have this multiple pregnancy, previous 3 medical, 1 missed, 2 ectopics, IVF, MCDA, 16 weeks cervical length was T-shaped, acute, not funnel at all, And at 20 weeks, you could see the funneling as well as some sludge was also seen. So Searchlite was placed on the same day progesterone was given. Preterm labor came fully dilated at 26 weeks. One of the baby was footling, did not survive, but the other baby survived and went home. So now I am coming to something different from prediction. So when a patient comes in labor, in preterm labor, we will diagnose it by presence of the contraction, or if there is cervical dilatation of 3 centimeter with effacement, we would call it as preterm labor. But all those who come with contractions may not end up in delivery within the next 48 hours. So only about 10% of these women who come in preterm labor will deliver within 7 days, and only 30% of preterm labor will spontaneously resolve, and 50% of patients are hospitalized for preterm give birth at term. So the problem is those who come in our labor with labor pains may not be in actual preterm labor, and do we need to admit all of them who come with pain? So here there is a method to stratify these preterm delivery patients into those which we need to admit them with a high risk for delivery, and those which may be sent home or just monitored and sent home. So for this, a transvaginal ultrasound and a fetal fibronectin may help us to reduce this unnecessary admissions and unnecessary tocolysis. So transvaginal cervical length is extremely important to assess the likelihood of delivery within 48 hours in patient with threatened preterm labor. So if I see a cervix like this, which is good, normal, 3 centimeter, I will not be worried, and they are very low risk for going into active labor and delivering within the next 7 days. So the chance is only 2% of these patients to go into labor. But if
Ma'am, you need to wind up.
yeah, just 2 more minutes, more, I'll finish off. But if it is less than 1.5 to 2 centimeter, then these are at high risk, and these patients will need to be admitted, started on steroids and other things. Two slides on fetal fibronectin, which is produced in the maternal decidua. If I find it beyond 22 weeks of gestation, they will be at higher risk for developing preterm labor, and this concentration of 50 nanogram. But fetal fibronectin is difficult, not available much in India. They have a high negative predictive value, cannot be used if there's vaginal bleeding or ruptured membrane or intercourse has happened or a PV examination. So if there is some research where you could do fetal fibronectin, it might help because it has a good negative predictive value. If it is not present in the cervical mucus, then the chance of preterm is less. But what we can do is also ultrasound assessment. And if our ultrasound assessment shows that the cervical length is more than 3 centimeters, so this is the third table, very important. Those who come in preterm labor, you could do a swab to see for infection. But if the cervical length is more than 3 centimeter dilatation, they are in active labor. But if it is not dilated, then you could do a transvaginal ultrasound. If it is more than 3 centimeter conservative, you can send her off, only give her steroids. If it is between 15 to 20 and 29, you could do a fetal fibronectin, but you could think that they might go into labor. But if it is less than 1.5 centimeter, they are into preterm labor. They need to be tocalized, steroids, Maxel, and managed as per the treatment for preterm labor. So this is the third important one for low risk patient, one for high risk patient, and one in threatened preterm labor. So these three protocols are important. And thank you, Asha Madam, for letting me speak on this topic of preterm labor. And I finish with that.
Thank you so much, Vandana ma'am. Requesting all the chairpersons, please take over, and your comments are awaited.
Yes, thank you very much, Dr. Das. Yes, he nicely said that cervical length, it should be assessed, and if it is less than 2.5 centimeter, can you hear?
Yes, sir, you're audible, sir.
Are you audible?
Yes, sir.
Yes, sir. Yes, sir.
Yeah. Thank you for significance of cervical length is very good actually you explained. If it is less than 2.5 centimeter, then we definitely consider for the cervical Searchlite and routinely give the vaginal progesterone. And so risk factors should be identified as you said. Prevention is very, very difficult actually. Once they go into labor, then it's not possible to prevent it. So you should identify the risk factor and then treat it. Thank you very much.
Thank you.
Dr. Seema, ma'am, you joined in late. Would you like to add a few words, ma'am? Dr. Seema Pandey, ma'am. I would like to thank Dr. Vandana for that very informative talk, ma'am. I'm sure all the people who attended today have benefited from this talk. We'll proceed to the next.
So Jashish, Seema ma'am is there. She can add comment if you want.
Yeah.
Oh.
Seema ma'am, can we have a few words from you?
Yes, sorry, bachcho, what has happened now? I opened the page and I went to a previous webinar and kept waiting for
Ma'am, I saw the message. Yes, ma'am. So
Yes,
please
yes.
just say a few
So,
words.
Dr. Vandana, it was an excellent talk, and I was just listening to though my camera was off, and it is really helpful for we the practitioners about knowing all these details. And Dr. Asha, it's an excellent program. Three cheers, and we need these kind of programs at our doorstep or at our fingertips so that we can keep updating our knowledge. So overall, wonderful, and thank you for making me a part of it.
Thank you. Thank you, Dr. Seema. Dr. Nagaratna, ma'am, also I could see.
Yeah, but ma'am's put a message that she's unable to unmute.
Listen, Bhavna, could you do something about it? Madam is unable to unmute.
Yeah, I can't do anything actually in that, ma'am. She has to join again, ma'am, and then join with computer audio. Maybe she hasn't clicked the option of joining with the computer audio.
Nagaratna, ma'am, you probably joined the wrong link. You know, the delegate link you must have joined. Please join from the Zoom link that has been sent to you. Yeah, madam is here.
Ma'am, she is there only. Nagaratna ma'am is here only, but maybe she has joined without clicking that option of joining with the audio.
Bhavna, make me co-host.
Yeah.
Make me co-host. And now, thank you so much, Vandana ma'am. You know, one great thing I saw was that you claiming that even you had to read some and you got some new knowledge. So that is hats off to your humility. But yes, as often as we read, we learn something new.
Yes.
That is for sure. So that was enlightening and a great reminder. Thanks a lot. And now we have Archana ma'am with us. Before she is formally introduced, she was the first one to come to Raipur after I took over as president. At that time, she was going to go for vice president, and the lecture that she gave on management of preterm labor has stayed in my head all these years. So as soon as I got this topic, I called her up and she kindly agreed to speak on it. So thanks a lot, ma'am. Over to you, Sujya, for the formal introductions.
So I will introduce the chairpersons of the second session. We have Bhavna, can you please share the slides? We have with us Dr. Mridula Sharma. Madam is the president of Bareilly Obstetric and Gynec Society. Next, we have Dr. Amita Shah, ma'am. She has graduated from MP Shah Medical College, Jamnagar. And Madam is currently practicing at a private hospital in Baroda since the last 30 years. She has worked as an honorary secretary in Baroda Obstetric Gynecological Society for 3 years. Madam has also presided over the Baroda Society since 1 year as a vice president. And Madam's areas of interest are adolescent health, menopause, infertility. Next, I would like to introduce Dr. Archana Dwivedi. Madam is currently standing for a chairperson of Foxy Midlife Management Committee. So wishing you all the best, ma'am. I now request you to please introduce the speaker. Dr. Amita, ma'am, would you please introduce the speaker, Dr. Archana Base?
Thank you. It's my proud privilege to be a chairperson in this live webinar, Core Connect, moderated by Dr. Asha Jain, who is also contesting for the chairperson for the Food and Drug Committee. My best wishes to you, ma'am, and thank you for providing me this opportunity. It's my honor to introduce Dr. Archana Basir, madam, who is a senior gynecologist at Indore, and she has enjoyed many prestigious positions like Vice President of Foxy 2020. She was the main organizing secretary for the beautiful conference AICOG 2021 at Indore, and she has also chaired the chairperson for Imaging Science Committee, and she is also the past president of the Fox Imaging Science Committee or the secretary for the ISAR 2016 and managing committee member. She is going to speak on a very important topic of the management of the preterm labor and especially the highlights of the management as per the guidelines. I invite you, Dr. Archana, for this prestigious talk.
Adding into it, Archana ma'am,
Yes.
you have been a very humble and down-to-earth person. I remember you, as madam said, the talk stays in our minds. So very great orator and a very humble person is here to speak upon. Thank you so much for being here, ma'am. Please go ahead.
Thank you, Dr. Archana. May I be allowed to share my screen?
Hi.
Hi, Seema.
Ma'am, you can share your screen.
Yeah, it's there. It's there.
Can you see my screen? Is my screen visible?
Yes, ma'am, we can see and hear you also. It
Yes.
is very
So
visible.
at the outset, let me thank Dr. Asha Jain for her invitation to me to talk on very important subject. And I really amazed by the memory she has of 2016-17 when I went to Raipur to talk on preterm labor. And I mean, it takes a lot of efforts to join so many societies: Orissa, Ajamgarh, Bengal Court, Bardhaman, Bareilly, Baroda, Barapeta, and Batinda. Kudos to you, Dr. Asha, for really bringing everybody on the one platform. And good to see friends Seema Pandey, Dr. Vanna Bansal, and all the chairpersons, who are here, Dr. Mradula, Dr. Anita, and Dr. Archana. I think my job is being made easy by Dr. Vandana Bansal, because it is like there is going to be an overlap when you talk about on the same subject about preterm labor. I have just changed while sitting here. I changed few things after listening to Vandana that I should not really repeat the same thing. So I am just putting my topic as management of preterm labor, old problem, new challenges. So, I mean, scope of my talk is our concern for being born too soon, new challenges like changing trends. Nowadays, we are coming with the late preterms, and preterm is a global burden, and complication, short term, long term, management and prevention. That will be my main focus on, and future and conclusions. I think Vanna has already covered that it is important because preterm accounts for 85% of all morbidity and mortality, and treating established preterm labor is unsuccessful. Hence, our focus is on prevention, and prevention is the key. If you look at the epidemiology of WHO, in India, about 27 million babies are born preterm everywhere and born every year, and 3.5 million babies are born premature. And we know that it's a global burden, and we as like in Southeastern Asia, South Asia, Sub-Saharan Africa, contribute to the preterm birth amongst the developing world. What is the new challenge? The new challenge is increasing number of preterm and the complication in extremely premature infant. But since we have now available different methods, we are getting the late preterm. And what is the problem with the late preterm? The problem with late preterm is increased prevalence of medical disabilities, learning difficulties, and behavior and psychological problem, among the surviving infants has raised concern that these infants may have difficulties in coping in adult life. Why I am bringing this point here? Because many of us think that now baby is 34 weeks, I will give steroids and deliver this baby. I have a good NICU cover and the baby will go home. It's not the baby going home we are responsible. We as an obstetrician, onus lies on us that our future generation should not have all these problems of medical disabilities and difficulties. So our aim should be not to deliver at 34 weeks unless like it's a maternal medical problems or something serious, but aim is to pull on to the pregnancy a little longer, as long as you can, and reach to the 37 weeks, because 34 to 37 is again a period, if the baby is born, is going to face difficulties in the adult life. The complications seen in preterm babies, neonatal problems, short-term problems, and long-term problems, I'm not going to go into the theoretical things. I have brought few practical tips for you all, so which I'm going to talk about. So how can you predict the preterm and prevent? I think very beautifully taken by Vandana again, that cervical length assessment and a history that is going to guide you that this woman is likely to have preterm labor. So what are the predictable causes of preterm labor? Past history of preterm labor, uterine anomalies, cervical anomalies, advanced maternal age, and assisted reproductive technology. Before 34 weeks delivery, 2/3 are spontaneous. Remember this, only 1/3 are iatrogenic. And out of that 2/3, 15% women had previous preterm and 85% had no previous preterm birth. So every woman is at risk of preterm delivery. You have to identify and you have to manage it. So cervical length measurement has been talked to you in detail, so not going into that. Just only to remember, TYVU is trans vaginal ultrasonography, so focus on that, TVU. So that is very important. I think this I'm going to skip. And when to screen, I think gestational age for ultrasound assessment of cervix in pregnancy, if there is a previous history of pregnancy around 14 to 16 weeks, and in private gravida or no history of birth, 18 to 20 weeks is the time when you are going to do that. Is it important that you intervene in all preterm? I think in recent decades, advances in newborn care have recently improved outcome for large number of children born too early, but this progress has not been reflected similarly in advances in our ability to prevent preterm birth. We are managing babies in NICU, but we have not been enough measures available to prevent the preterm birth. So we now have increasing evidence that variety of interventions have potential to significantly and to a safety, a meaningful proportion of preterm birth. So what are the interventions available to us? I think already been talked about that you have progesterone supplements, you have surgical closure of cervix, prevention of exposure of women to cigarette smoking. Just highlighting this because in India it was supposed to be that our women don't do this smoking and all, but recently what we have been noticing that this has been increasing in our population also. So these things also have to be taken in the history and ideally advised not to do smoking. Judicious use of fertility treatment and dedicated, I'm going to focus on dedicated preterm birth prevention clinics. Progesterone supplement, all of you know how to give progesterone supplement and beneficial effect of progesterone and route of administration. Does the length of cervix makes a difference? Yes, it does. Shorter is the length of cervix, lesser are the beneficial effect of the progesterone, and we all know. So now this Arabin pessary, I think it's a flexible round cone-shaped pessary. We have used it. We have been a part of this study. I think Dr. Naren Malhotra and team did in Agra, and we asked them to give Arabin pessary for one of our patient who was 28 weeks and has a bulging membrane, and we did not feel that it was appropriate to do the rescue cerclage in her. We put it at 28 weeks and we could carry on pregnancy till 34 weeks. It is available and it's a very good method. which is a non-surgical means to help prevent the preterm birth. When you can't prevent preterm going into preterm, but if you know that this woman is going to have preterm birth, you can use the pessary, and it supports the cervix in a manner that it also compresses it at the same time, causing it to close and possibly change its direction more towards the sacrum. So I think this was one thing which I wanted to brought up here. And there was a study, like I've already talked about Dr. Malhotra's study, that they did it in 50 women with singleton pregnancy with short cervix, and 98% of women gave birth to live births with only one neonatal death due to prematurity and pneumonitis. So this is what in the sagittal 12-weighted magnetic resonance image after putting the Erbil pessary, what they found that the cervical length angle, basically when we learn about the cervical length measurement, we see not only the length, it is the direction of the cervix is also important. If it is straight, likelihood of going into the preterm birth is high, and if it is curved, it is going to be less. So these are the tocolytics. I think I need not talk in detail to all the gynecologists who are attending here. You have nifedipine, you have magnesium sulfate, beta mimetics, atosiban, and nitric oxide. So the surgical intervention is something which I really want to focus. We all know transvaginal McDonald suture, Shirodkar suture. I have brought my video, which last time when I promised the Raipur people that I'm going to be sharing, and somehow I could not share and talk to them. So this is our method of transvaginal intraperitoneal transsystemic cervical suturing, for which we got the even Foxy Korean award as well. So this is the method which we have a little bit modified and got the very good result. We have a study, 25 patients on this, and they had a good this thing. So the cervical cerclage, should you be putting cervical cerclage in all? The decision to insert a cerclage in mid-pregnancy is based on 3 scenarios: if there is a history of preterm birth, or if there is a second is shortening of the cervix on ultrasound imaging, and third, if you have dilated cervix on examination. And you have laparoscopic cerclage. It's important that when you do the timing of cerclage, interval cerclage performed prior to pregnancy, technically easier manipulation of uterus, but you can do it if you are really level 3, level 4 laparoscopies you are doing. I'm sure you can do the laparoscopic cerclage, and many of us are now doing the laparoscopic cerclage. There's a lower risk of bleeding and complications and reduced surgical problems. And there are post-conception non-interval cerclage are also there. It can be done effectively, electively between 12 to 14 weeks of pregnancy, and minor increased risk of surgical complication like bladder injuries or can be there. The steps of laparoscopic cerclage, it is not a forum where you are endoscopic surgeons, but still it is, once you learn, it is quite simple. So you just have to open the peritoneum over the anterior uterine isthmus, and with your needle, you just pass the Marcelline tape and tie it in the front. So these are the pictures of this. This is from our friend, which I recently borrowed the pictures, because I found that it was very nice pictures. So this is how you open the peritoneum, and then go with your Marcelline tape, tie it here, and it is very good method. This is our method of transcervical, transvaginal, transischemic, intraperitoneal cervical cerclage with our modification, which is what I'm just going to talk in a little detail, because this can be done by any gynecologist who is doing vaginal surgery. Like if you are trained to do vaginal hysterectomies, you know how to open the posterior peritoneum, you will be able to do it, and it is very, very effective. Especially we did it in our patients who had previous 2, 3, 4 mid-trimester miscarriages, and we found that it was very, very effective, and it is done under spinal anesthesia. Put the patient in lithotomy, give a 2 to 3 centimeter wide transverse incision on anterior vaginal wall, reflect the bladder, don't open the anterior peritoneum while posterior peritoneum is open, and after opening the posterior peritoneum, your Marcelline tape, you from the both ends, like right and left side, you bring it to the anterior and take it out from the anterior vaginal wall. I'll just show you the video how it is done. So that will be, this is just an illustration which we have published in our book. So this is semicircular incision on anterior cervix, which is very well can be seen on this picture. And then open the posterior peritoneum by the knife. After opening the posterior peritoneum with a needle holder, our needle holder is a little curved needle holder. This is the tape you can see with the needle. You have to avoid the vascular bundle of the uterine artery. Just palpate the uterosacral ligament and go by side and look at here that this is being brought in the front. Both the ends of the tape are brought in the front. This method has been described by others also, but what others have done, they have tied the knot here only and then covered the anterior peritoneum and sutured it with the cervix. What we have done is we have brought this thing from the anterior cut end of the vagina and we have tied here. Why? Because in labor, if patient comes, it is easy because you don't have to make a cut and open your suture. You just can cut and you open, so that's easy to do. And just look at the video if you. So this is a video, 5 minutes video, where we have described this method and this is something which is very, very doable thing, and especially in the women who have previous mid-trimester abortions. So what we are doing here is just made a opening in the anterior vagina and just lifting the anterior peritoneum to see that this bladder is not there. We are just going to reflect the bladder up and then opening the posterior peritoneum. I think all gynecologists doing the surgery, vaginal surgery, would be able to do this. And then just put your speculum in the open posterior pouch, right? And you take your suture. What is most important is that it should not twist. So brief your team. Look at here that with the uterosacral, I'm taking my needle here. My team knows what exactly I'm going to do, and they've been working with me since long. I do brief them that what are we going to be doing. So the needle, I palpate it anteriorly with the finger that where the needle has to come. So needle has come here anteriorly. It is little tough because marceline is not a very easy material to handle. So the needle is being pulled out. It takes a little effort. So we put a little this paraffin oil or jelly so that it glides through with a needle nicely. And one person will make sure that I don't turn and twist my tape. So otherwise, if it turn and twist, we are going to lose its effectiveness. So this is now we are taking it from the posterior part, and then what this picture you will not see, but because this is our initial case where we put endoscope, telescope, hysteroscope, just to see that our placement is no fine. But after we have done many cases, we have stopped putting the hysteroscope in the pouch and see that how it is doing, it is being placed properly or not. So just the needle is coming from the right side, for initially left side, whichever side you want to do, you can do that. And after we are doing this, we are going to be pulling it a little bit, and like how you do in your McDonald's, like look at this, both the tape ends are there with me now. So I'm just seeing that I'm not engulfed anything. So just going to pull it clean, and then I'm going to take this needle. What others will do, they will tie it here only. But I am going to take my needle through the anterior vagina and tie it above that. Some might say that there will be irritation to the bladder. I mean, it's not very clearly seen, but you can see the tape here. You can see tape here. It is at the isthmus. So the name is, it is isthmic. It increases definitely effectively. Now you see, I'm coming through the anterior vaginal wall and bringing my needle here outside, and from the left side, and similarly we will be doing it from the right side. And most of our patients went up to, I mean, we have a series, most of our patients went up to 34 weeks, and a couple of patients had a vaginal birth. But yes, because these patients are otherwise someone had breech or some high risk, so they went up. Then we needed to do LSCS, and when we did LSCS, we could see when you are doing your cesarean section, that posteriorly we could see that our tape is there intraperitoneally, very well placed. So this is, again, we are trying to make sure that we are not, damaging the bladder. So this is, the bladder is being pushed well, not opening the anterior peritoneum. That's the important thing. And this is the needle is coming from here. And I just put some vicryl sutures on the anterior cut, which I did, and 2-3 vicryl sutures on the posterior vaginal wall. So we are just going to tie this here, increasing the length effectively. A little bit bleeding is going to be encountered since patient is pregnant, and in the pregnancy around 12 to 14 weeks, you know that there is a increased vascularity. We'll just tie this and put the sutures, vicryl sutures around. And I'll show you the final picture, how it looks like. So this is the final picture, how it looks like. The tape is here anteriorly, closed with the vicryl. All our incisions we have closed. And just cleaning a little bit. And this is the final thing. This is the tape, and these are the vicryl sutures on the anterior, and this is on the posterior vaginal wall. Incision is being sutured. So let's move on. I hope that this is helpful to people who are really struggling with recurrent mid-trimester abortions and are like not having a McDonald suture effective. And this was the posterior vaginal suture at C-section, as I said, and this is the healthy baby after our TIPP video. And let's move to the next. Rescue cerclage. I think Vandana did speak about rescue cerclage. She had a case where she presented like how they did the rescue cerclage, and though that they had a problem and their baby delivered around 20 weeks. But this is a rescue cerclage, which this is the way we do our rescue cerclage. And we have found this is a very effective method. I know that cervix has to be 3 to 4 centimeters dilated. If you see this bulging membranes, your heart starts pounding that I hope I don't break these membranes. So again, we do briefing. This patient, I remember, came for again a routine scan of anomaly scan at 23 weeks. And my sonologist from the floor, they called me that, madam, she has a dilatation of cervix. Patient came totally unprepared. We did a lot of counseling and put up a cervical rescue cerclage. What we do, we put a Foley's catheter, inflate it. So with the balloon, if you put a gauze piece with a sponge holding, you are likely to rupture the membranes. We put with the Foley's, push the membranes behind, and I'm taking few umbrella sutures. These umbrella sutures are just so that membranes have gone pushed up, and after doing this umbrella sutures, my assistants and associates are holding these sutures. 3 umbrella sutures I will take from anterior to posterior, and then I'm going to take the circumferential suture, because initially if you try to take all around suture, you don't know that your membranes are, where are your membranes. So this is how we do, and we found that it's very, very effective, and many patients come to us for the rescue cerclage, and even many of our colleagues come to learn that how do you do rescue cerclage. So this is the way we do our rescue cerclage. And now let's just see the final picture of rescue cerclage. Again, what do you do with this vicryl sutures? Because this I'm using the silk here, and then this vicryl sutures may be left in place because they are going to dissolve at the end. Because if you try to cut them, then you might encounter the bleeding. So we leave it as it is, but we do deflate the Foley's catheter and remove the Foley's catheter. And we do put a catheter in the bladder so that the bladder is empty before we took this, before we take this cervical suture. So this is our rescue cerclage. I think because all things were already covered, I thought I just changed it so that I give the practical tips here about the prevention and management of preterm labor to all of you who are attending here. And this is how just you take the circular. I know it is very, very thinned out cervix with the dilatation, and it is very challenging. But if you know and your team knows what you're planning to do, it does work out. And I'm sure many of you must have already done the rescue cerclage and found that yes. So this patient delivered at 34 weeks with us, went up to 34 weeks. We had to do C-section because she had breech presentation and oligohydramnios with the breech, and she had a healthy baby girl at 34 weeks. So this is just you are tying your knot and then you are going to remove the Foley's catheter. And one of my associate will take the Foley's catheter out, and this is the final picture of rescue cerclage, which is being tied. And okay, let's go on to the now. I think this is already being taught. So, and then the question is, should all pregnant women be screened for cervical length is already being answered. These are the nice guideline recommendation. That guideline includes new and updated recommendation on prophylactic vaginal progesterone, magnesium sulfate prophylaxis, intrapartum antibiotic, diagnosing and caring the women with preterm labor rupture of membrane, diagnosing preterm labor, tocolysis, maternal steroids, fetal monitoring, mode of birth, and clamping the cord, information and support. And these are the FIGO guidelines talking about the transvaginal ultrasound between 19 to 23 weeks for cervical length, which already, this is my something which I wanted to bring here before I end, that we should have dedicated preterm birth prevention clinic. In recent years, many health hospitals are dedicating preterm prevention clinics. And these clinics, what are they doing? They are focusing on newer diagnostic and therapeutic interventions, assessment of vaginal microbiology, fibronectic testing, ultrasound detection of short length of cervix, antibiotic use, progesterone therapy, and cervical cerclage and urban cervical pessaries. So strategies with promise but requires more research is treatment of intrauterine infection, nutritional intervention, ameliorate maternal stress, treatment of periodontal disease, and prevention of surgical treatment for cervical intraepithelial neoplasia. Just to summarize, in most countries, the rate of preterm birth has been risen in recent decades. Worldwide now represent the largest cause of neonatal death and second largest cause of death in children up to 5 years of age. So remember, it's not only the early neonatal or late neonatal death. The babies who are born preterm, they are at a high risk of death even till the age of 5. And discovering how to lower the rate of major complication of preterm needs to be one of the highest priority in contemporary health services. So thank you very much. This is our recent publication, Preterm Labor Identification and Management, which we unveiled at AICOG Hyderabad, and Dr. Vandana Bansal was one of the person who was there when we inaugurated this book. So thank you very much to all of you for patience listening.
Thank you, Archana ma'am. And I think with this audio-visual insight, as you talked about both types of cerclage, the things seems more manageable. To conclude, I would like to say that it is a very good session where we are learning to establish a dedicated preterm prevention centers, which is the need of our, as Madam has already pointed out. The increasing preterm birth is just not an immediate burden, but a burden to the parent and the society as late as 5 to 10 years also. So effective prediction and picking up the silent cases is a very important tool for us in our hands itself by judicious use of technologies and ultrasound and predictor valuables which we have with us. And interventions, as Madam already said, are very significant, and safety preventive potentials are by and large very good. So, Madam, it was a very mesmerizing session seeing your videos. And Rescue Searchlite, I know it has saved many lives, and probably with this good audiovisual connect with you. Thank you, Asha ma'am, for being pivotal for getting these videos to us. And thank you so much, ma'am. It was enlightening for all of us, I think so.
Thank
And
you, Dr. Archana.
Thank you,
enjoyed it
Archana
thoroughly.
ma'am. If you could share that video in the group, we would
I
be
will.
really.
I will share.
I would
I will
just
share
like to
because
say-
I want everybody to learn, and it is very easy because we all are doing vaginal surgeries, so it is not difficult.
So I think Madam has given a very good flap. The first video, we could see the flap to be taken easily, and it seems very manageable, Madam. So
It
thank you
is.
so much for that. And at this platform, I would like everybody to request and support, seeking blessings from all of you for the Midlife Management Committee elections 2024, which I'm going to be there. And also such a dedicated person like Asha Madam. No need to say she's the rightful person to stand up for the Food and Drug Committee. So both of us are looking forward to your support. Thank you so much, Asha ma'am, for giving me this opportunity. Thank you so much.
All the best, Archana.
Thank you, ma'am.
मैम ऑल द बेस्ट मुझे भी कह दीजिए आशीर्वाद आपका चाहिए
तुमको तो बोलना ही है because food and
Very
drug is an important part of
Very
preventing preterm. Because if women are fed well, they are not going to have preterm.
Thank you so much.
Thank you so much for
We
opportunity.
have Dr. Mrudula Sharma also say a few words. Ma'am would like to say a few concluding remarks.
Mridula ma'am,
Are you there?
I don't
Ma'am,
see.
Dr. Amita ma'am, would you want to add something, ma'am?
Yeah,
It
Amita
was
Shah
an
madam is
excellent
there.
presentation. It was fine, and everything has been summarized so nicely. It was a very useful video also, and a very nice presentation, Archana. Thank you.
Thank you so much. And, I would like to start the panel immediately because we have really great panelists and it would not be good. Our expert today is Dr. Manjeet Singh Sidhu, who's the president of Bathinda Society, a very senior gynecologist. Special interests are advanced vaginal surgery and lap surgery. Next, please. We have our panelists, Dr. Archana Massey ma'am, who's the secretary of Azamgarh Obstetric Gynec Society. Dr. Shobha Shaivi, secretary, Bagalkot Society, and she is also a fetal medicine expert. We have Dr. Gayatri Singh, who's the secretary of Bareilly Obstetric Gynec Society. Dr. Reshmi Banerjee, who's the secretary-elect of Vadodara Society, and she's an ardent animal activist. Dr. Hemkant Sharma, unfortunately, has not been able to join us because there's been some family emergency. He is the past secretary of Barpeta Society. Then we have Dr. Simi Agarwal, who's a senior obstetrician at Bathinda. When I called the secretary, I said, you please share somebody good with me. And she shared Dr. Simi. So welcome, Dr. Simi. We have Dr. Sasmita Swain, ma'am, who's the secretary of Association of Obstetricians and Gynecologists of Orissa, a very, very senior gynecologist with areas of interest, safe motherhood, high-risk pregnancy, infertility, and geriatrics. And we also have Dr. Amit Datta, who's a senior specialist, HOD, Shanti Niketan Medical College, and Director, Park Nursing Home at Bardhaman, West Bengal. Welcome all my respected panelists, and I hope we have had such great speakers that this would basically be just
A revision of everything.
Yeah, basically a revision, but not just a revision. Because as you know, we may study everything, but when it comes to application, there are things that keep happening. And we have questions. Aisa kare ki aisa kare? What to do? So we are going to start our panel on preterm labor with one situation. Dr. Vandana ma'am has spoken a lot on the guidelines. Archana ma'am has also spoken on guidelines, NICE guidelines, AOCOG guidelines, Green Top guidelines. You've heard everything. Now we start with what we are going to do. So here is a patient, a 38-year-old, Gravida 4, Para 0, abortion 3. And they are all first trimester miscarriages. She reports with a positive pregnancy test for the first time in the OPD. Now, once a lady such as this has come to your OPD, what are you going to do? What are you going to do?
Anyone can take the question, ma'am.
Anybody can take the question and let's have it rapid.
Okay. Thank you, Asha ma'am, for making us a part of this prestigious webinar. So when a patient walks in my OPD, I will first of all take a detailed history regarding the circumstances of the abortion. So whether there was any triggering factor, whether there was any recurring factor, whether she has had any history of infertility, any treatment taken, any past history of uterine manipulation, also previous abortions, whether they were DNC was done or whether it was medical abortion. And of course, the most important would be a sonography for dating sonography and also to look at her pelvic organs.
So, ma'am, would you prefer an abdominal scan or would you prefer a vaginal scan? Transvaginal scan.
Without any doubt.
So now a transvaginal scan was done and she had a septate uterus with a septa which was up to 0.5 centimeter above the internal os, and there was a pregnancy in the right side of her uterus. Now, what will you suspect and what will you counsel?
In this case, ma'am, can I speak?
Who's speaking?
Please, ma'am, please.
Dr. Simi.
Yes, Imid.
Yeah.
Please go ahead.
Ma'am, in this case, the septate uterus scan is present just above, landing up to just above the internal os, 0.5 centimeters. So this can also be a reason for the recurrent miscarriages that she's having. So over here, the reason for the septa can be because it is not giving proper blood supply. It is an avascular structure. So the decidulization does not properly occur and these abortions can happen again and again. This can be the reason for her abortions.
Sadhu sir, would you like to add something? What will you counsel the patient?
Ma'am, counseling in this case can be that if she lands up into abortion this time again, then she has to undergo the resection of the septa after this. But somehow she'll have to continue with this one.
Can I add, ma'am? Can I
Yes,
add?
yes, Dr. Shobha.
In this case, madam, like along with TVS, abdominal scan with 3D is also needed to properly know what it is exactly, the actual uterine anomaly. Once we know what is the anomaly in this uterus, we have to counsel the patient that it can be one of the reasons for our multiple abortions. And in this pregnancy also, she has a very high risk of having an abortion. And she might also need a stitch also, cervical stitch also, if the pregnancy continues beyond 14. And if she aborts again, she'll need a hysteroscopic evaluation later to know the exact anomaly and to also to treat the same.
I would like to ask Sasmita ma'am, who's another very senior person. Dr. Sasmita, would you like to go ahead if she is carrying her pregnancy? Do you want to give a stitch?
Stitch at this time depends on what is the gestational age.
No, means if she carries to 12 weeks, would you want to give a stitch? See, she
Usually
has had
uterine
3
anomalies,
first trimester abortions.
that is first time abortion, usually they are because due to chromosomal anomalies. But this patient is having a septa. Sometimes there may be associated congenital cervical incompetence also. So we have to follow up the case. If between 16 to 24 weeks we find that the cervical length is decreasing or less than 2.5, then I have to go for a circlage. That depends. We
Okay,
have to
but
go
you
for
would
the
not
cervical.
empirically do it.
Empirically, I
Yeah,
will
it depends on ultrasound finding.
ultrasound finding.
Sidhu sir, would you like to add something?
They've already said that cervical encerclage may be required if the cervical findings so suggest. In addition, progesterone must be given in such cases, and NICE guidelines say that vaginal progesterone has to be given in case like this. We have to be very careful that preterm labor does not occur. Firstly, it is the first. The history says that she has had first trimester abortions only. But now that we have the finding of a septum, we have to be careful about the pregnancy being terminated early by preterm labor. So both the things we have to keep in mind: progesterone as well as cervical encerclage if indicated.
So when are we going to start the progesterone?
Immediately on diagnosis of the
Immediately on diagnosis
intrauterine
of
pregnancy.
pregnancy.
Okay, anyone disagrees to this or everybody is agreeable to this?
We are all agree. Usually we are giving.
As soon
Okay.
as we diagnose this.
Okay, okay. So, Amit sir, you want to say something?
Ma'am, no, definitely I agree to the panel, what has been discussed.
So now I think we want everyone one by one. What is preterm labor?
Ma'am, any delivery which is occurring before 37 weeks of pregnancy.
Then what is preterm birth? What is the difference between preterm labor and preterm birth?
Preterm, can I take this question?
Yeah, go ahead.
Hello. Preterm labor is when there is a contraction and with little dilatation of the cervix has started. But it does not mean that she will end in the preterm labor birth. In many cases, preterm labor will subside and she will not go into preterm birth.
Okay, that is a very important point that I wanted brought up.
Preterm labor can be diagnosed, threatened preterm labor, it may be diagnosed preterm labor, or it may be established preterm labor, which usually land with preterm birth. But in threatened preterm labor, where there will be uterine contraction, but the cervix will not be dilated. And in established diagnosed preterm labor, there will be contraction. Along with that, cervix will be dilated, but it will be less than 4 centimeters. If it is dilated more than 4 centimeters, we tell it is a established preterm labor, where we may not be except that rescue stitch. We may not able to prevent the preterm birth.
Okay. So can preterm labor stop on its own? You've done nothing and still the pains came and they went away.
Yes,
Yes,
ma'am.
ma'am.
Every
10%
30% cases it stops on its own. 30% cases it can stop it on its own.
Okay. So what are the signs and symptoms of preterm labor other than contractions?
There may be vaginal discharge, there may be some bleeding, and there may be persistent dull ache and pains. There may be more increased frequency of urine and
heaviness in the pelvis.
Pelvic heaviness.
I want to ask one question because of the experience that I have had. Is it possible to have preterm labor without uterine contractions?
Yes.
Yes.
Sometimes.
In cases of cervical incompetence,
No cervical incompetence. Uterus is relaxed, cervix is tightly closed. Can that still be preterm labor?
If there is leaking of amniotic fluid.
No leaking.
Achha.
Yes, it can occur.
Means that this case that I am discussing, that is what happened with us.
effacement, if there's only effacement of the cervix and no dilatation, then that can be termed as also preterm labor. Like if there's
what are the risk factors here in this case?
There is a septum and there is a history of multiple miscarriages.
And
age.
Age.
And
Age, 38-year-old lady.
So these are the various guidelines that we have, the key recommendations, what to do, what not to do. So we are not going to take this because you're all experts. So we have the risk factors. And she did not have any past procedures on the cervix or anything. And there was no delivery previously. She didn't have any DNC. They were all missed abortions type of, that she went for a scan at 8 and there was, nothing that way. So she was of a BMI of 27. So it was not a low pre-pregnancy weight, no tobacco, nothing. Then this is the chart that is advised, screening checklist. So can somebody describe this checklist? Because in the uterine anomaly, it does not mention septum. Yes, bicornuate, yes, uterus diadelphys, yes, but it doesn't mention septum. But it's here.
Yes, septum will not lead to preterm. Septum usually lead to recurrent missed abortion or the early trimester abortions.
Yes.
Anybody wants to add something to this?
Septum can lead, ma'am, a malpresentation, placenta previa, all these complications.
Okay. So now what happened that we did an NT scan. That was at 12 weeks, 5 days. The CRL was 65 mm, NT 1.8. Ductus normal, no tricuspid regurgitation. Cervix was 2.6 centimeter. Uterine artery PI was at 60th percentile and there was no anomaly seen in the first scan. The combined screening was low risk for trisomy, low risk for PIH, and low risk for preterm labor. Okay. Now, at this stage, would any of you want to put in a stitch?
Ma'am, cervical length is somewhere around 2.6.
Ma'am, because this is first trimester. This is not the 20-week scan. In the first trimester, your uterus only is small, right?
Ma'am, serial ultrasound, TVS for a gradual measurement of cervical length is
But that is
required
what
there.
Dr. Bandana said, what Archana ma'am said, that is depends on the 18-week scan.
Ma'am, we will add progesterone.
Progesterone you've already added, right? You've seen her past history and she's on progesterone. Then we went to the mid-trimester anomaly scan. So no anomaly was detected, growth was appropriate, uterine artery PI was at the 50th percentile and the cervix was 3.2 centimeter. Okay, now what next?
We'll continue the pregnancy, ma'am.
Anything special that you're going to guard against?
Infection, ma'am. You will guard against infection.
Okay, and what will you do to guard against infection? What are you actually going to do?
Ma'am, we'll go for checking of the vaginal fluid, GBS.
Just like that. At 20 weeks, you would just do that.
No.
We'll take a high cervical swab and high vaginal swabs can be sent, and look out for signs of infection like a foul smelling vaginal
But why?
discharge.
Why? This is an entirely normal scan at 20 weeks. So will you do a vaginal swab? She has no discharge. She has no complaints. She's very happy that she's carried to 20 weeks.
If she's no, if she has no symptoms, we don't do any test.
And just
we don't understand.
I'll screen her for diabetes, GDM, because she is 38-year-old. So
Hypertension can be.
So you would do a GDM And you would also do a urine culture, right?
Routine.
Yes.
So this is the algorithm. You've done this and she doesn't fall in any of the initial risk. She doesn't fall in any of the further risk as well. You've seen the whole assessment. She doesn't fall anywhere in that. So she's basically, she had that history of first trimester abortion. Now she's fine. Now she comes to you at 26 weeks. Presents with severe pain in the back. The pain is continuous. The uterus is 28 weeks relaxed. There's no leaking. Cervix is posteriorly placed and elongated. There are 30 to 32 pus cells in her urine.
So this is a case of
Urine
UTI with probably pyelonephritis also.
UTI, yeah.
Urine culture and sensitivity, ma'am.
Okay. And see, your culture will arrive in
3 days.
3 days.
3 days.
Or
Prophylactic.
earliest is 48 hours. So what are you going to give her meanwhile?
We'll give her some broad spectrum antibiotic, hydration.
So what
And
is the
maybe
antibiotic of choice? You are a very knowledgeable panel. So please, which antibiotic would you prefer to give?
either
Ma'am, they-
cephalosporin group.
Cephalosporin.
Usually cephalosporin.
Usually, ma'am, azithromycin to start with.
Anybody has any experience with phosphomycin?
I
Yes,
usually
yes.
give
Yeah,
phosphomycin.
we do give like phosphomycin definitely I use, but at least I would not want to give it empirically. I will give cephalosporin initially, and if the sensitivity report comes, then I would add phosphomycin. Add
Dr. Amit, would you differ?
Yes, ma'am. Phosphomycin initially we would not like to start straight away.
Dr.
Either we
Simi?
go for Keftam or that cephalosporin or azithromycin.
Dr. Simi?
Ma'am, cephalosporin is my preferred choice
And
for antibiotics.
we usually give nitrofurantoin. In UTI in pregnancy, nitrofurantoin is the drug of choice.
Ma'am, but it is a bacteriostatic and it doesn't really work, you know. It's a
And we can give
bacteriostatic.
we
And
can
you
give
cannot use
those
it for a very long time.
urinary alkalizer to change the pH.
Okay.
And
I
like
use
usually most common is E. coli. Then we
phosphomycin
can add
quite
cranberry
frequently.
extracts, or if she's not a diabetic, we can give cranberry juice. These are I mean these can be given for the first 48 hours. If she has fever, then I mean in my personal
No fever.
practice, the
No
patient has a
fever. She doesn't have any fever.
So in this patient, at least I would keep phosphomycin as on hold to be used in resistant cases and not
No,
empirically.
phosphomycin is not the drug of choice, first drug of choice in UTI in pregnancy. Nitrofurantoin or cephalosporin or penicillin group is the drug of choice. And you can start that until the culture report comes.
Dr. Shobha?
No, I usually start with ceftriaxone only most of the time, till the result comes, culture sensitivity.
Dr. Gayatri?
Cephalosporin is the drug of choice of my
Sujaya?
OPD.
Cephalosporins, ma'am. Cephalosporins.
Cephalosporins, ma'am.
Okay, so everybody agrees to cephalosporins. Okay, so she was
Ma'am,
given
you agree with the same or you have
Keftam
any?
500 BD. We gave her Drotin. Now the patient is relieved. She was sent home. Now my question is, should I have sent her home or should I not have sent her home?
Sent her home, ma'am.
Send her home.
That's
And
okay.
corticosteroids to be added, ma'am. Because 24 to, this is the time, 26, 24 to 34, we add corticosteroids and then send her home.
So, but in the question of corticosteroids, she has to deliver within 7 days. Then only those corticosteroids are effective.
Not
So,
at all in preterm labor. So why should you add corticosteroids?
so everybody agrees that she's not in preterm
Yes.
labor, right?
Yes, 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 ma'am. Yes, ma'am.
So
We
now
agree
what
that
are we
she's not
going to
in labor.
counsel her?
She should take the
Ma'am.
antibiotics properly, evacuate the bladder frequently, take plenty of water. And if she develops contraction or fever, she should report immediately.
Come back when culture and sensitivity report comes, so that we can start her on.
Yes.
And she has to report if she will have leaking, bleeding, or any abnormal discharge.
So
And you
this is a question that we've already done.
Ma'am, in the group chat, someone has mentioned fetal fibronectin. So would you want to comment about that?
Why fibronectin? She's still not in labor, right?
Right, ma'am.
There
That
is
was
a
a question.
history of leak or any history of pain, then fetal fibronectin would have been advised. But in this case,
Practically, how many people are doing fetal fibronectin?
Fibronectin is not available everywhere.
Yeah, it's
We
not
can,
available in my city at least.
other is
Now,
we can go for cervical
3
labor.
days later, she comes at 8 p.m. with severe pain, which is again continuous, and the patient is unable to lie down. Uterus is relaxed. On a CTG, no uterine contraction is seen. Fetal tracing is normal. Ultrasound 27 weeks, normal growth and Dopplers, placenta normal, no bleed, but the cervix now is 2 centimeters. Now she is hospitalized for observation and given dexamethasone 4 doses. Okay, 6 milligram.
6 milligram.
12 hours apart.
6 hours. Now you tell me, would you have done something else?
put a rescue Searchlite. If
Means there are no contractions, the uterus is relaxed.
But she's
There's
too
no leaking or anything, and the pain is continuous. It's not intermittent pain like contractions.
It's, madam, 2 centimeter cervical dilatation is there, which shows that the
It's not dilatation. The cervical length is 2 centimeters.
Sorry, so cervical length 2 centimeters itself is, you may not put in an encirclage, but at least she is, see, I mean, in my practice, rather than an absolute, well, if the patient is coming to me regularly, a progressive decrease in the cervical length is equally important than an absolute cervical length. And here, UTI itself is an risk factor for preterm labor.
Okay.
So I may put her, I mean, I can give her tocolytics at this stage and wait for the culture report under cover of
Culture, it's
antibiotics.
3 days, culture report has come.
Yeah.
The antibiotic that we have given had sensitivity. So now she's cured of her urine infection. We had given it, this was 3 days back. Now she doesn't have a uterine infection. The urinary
So here the madam, the internal os diameter or whether funneling is present or not.
There's no funneling, nothing. It's just that the length is less.
But when the uterus
being the
is relaxed,
cervical length is 2 centimeters, so we'll give vaginal progesterones.
She's already on vaginal
vaginal.
Would you admit her or would you let her go?
No, now admit her.
Admit and start her on tocolytics.
We have to find out the
Now
cause
she is
of
hospitalized. After 2 days, she has sudden increase in pain, which is now intermittent. Cervix is admitting 1 finger. Now what?
Tocolytics.
Now you have to start.
We've already given her dexamethasone. What is the role of tocolytics and for how long are tocolytics indicated?
Up to 48 hours.
Tocolytics
Are
up to 48
actually
hours.
indicated only to give
For transfer,
steroid
whether
cover,
to shift
right?
the patient, shift the
Till the
patient or
steroid
to
action is complete.
buy time for the steroids.
No, she's already received the steroid.
Yeah, that is, no, I'm seeing indication for tocolytics.
Yeah.
So
she
I
has
think now,
already
madam, I
received
would
the
really
steroid.
consider putting in a stitch.
Would you put in a stitch at this stage?
If there are strong contractions, stitch may
I
not.
would, madam, in view
No.
of her past history of previous 3 first trimester miscarriages, this is a precious pregnancy. She's 38 years old. I would definitely want to put in a stitch.
Ma'am, but
As a
with
surgeon, I think so.
with stitches, it would not really work. It
Is
didn't work.
stitches
And she delivered a
not
preterm vaginal delivery, 800 grams fetus by vertex. The baby cried immediately. Now, what are the precautions in delivering such babies? Could not stop the labor.
Yeah,
She
generous episiotomy and avoid instrumental delivery to avoid head compression.
Okay. And do you want a neonatologist present?
Yes.
Neonatologist should absolutely be present over there, and
There
the
should
baby
be
has to be
the
admitted into
neonatal.
Patient should be ready to go to the nursery. The baby should be ready to go to the nursery.
Immediately following
It has
that,
cried immediately and everything. You still want the baby to go to the nursery?
Yes.
Yes, yes.
Yes.
Okay. So now, what postpartum, you have to counsel the patient. The baby has been sent to the nursery, right? So what would you be alert about? What are the early complications expected in the baby?
Respiratory
Yes.
distress, respiratory
Infection,
symptoms can be present.
infection, respiratory distress.
Very
And
important is hypothermia, hypoglycemia, infections. These three things you have to take care of. So immediately after delivery, you have to wrap the baby, keep her in the warmer. And if baby is not crying properly, nowadays movable ventilator is also available, which you can keep in the OT itself. And from the OT itself, you with the ventilator, you can send the baby to the NICU. That is very important. So neonatologist has to be present. Take all care immediately following delivery. Hypothermia is very important. And hypoglycemia, they are very prone. And all aseptic methods should be maintained because most common site source of infection is immediately following delivery. If you don't take the baby, because what happens in government hospital, every time a sterile towel is not available. Immediately after delivery, baby will catch up the infection and septicemia. These are very prone to develop septicemia. That is very important. And 800, they have to be on
parental nutrition.
And oxygen, that is also very important. Too much oxygen, they usually land up with retinopathy of prematurity, ROP. So that also you have to always keep in mind. So ophthalmologist should be see the baby after hand so that it does not develop blindness. That is a very common cause of blindness nowadays because of over treatment of the premature baby. That we all have to keep in mind. That ROP test has to be done in all cases of preterm babies. And another is your BERA test for audiometry. That has to be also done. That is also very important. And baby should be handled by the neonatologist in the NICU.
okay. Any other late complication that you might find in such babies? गायत्री मैम आप बहुत देर से बोल नहीं रहे हैं.
There may be, ma'am, learning disabilities will be possible here, or the neurodevelopment is late, may be complicated here.
And
There
cerebral
may be
palsy.
some,
Cerebral
cerebral
palsy
palsy,
is very, very important.
hearing loss or visual defects or delay may be there.
Now, how would you plan for the next pregnancy?
Madam, before
Ma'am,
that,
she
I'd
should
like
be
to add one
counseled.
more thing. This
Yes.
lady might have retained placenta. So third stage must be
She
usually
didn't have retained placenta.
they can have whenever
Yeah.
there is a septate
Yeah.
uterus, and removal can be quite difficult in such cases, madam.
Yeah. Means she had an anterior placenta, so it didn't really cause a problem.
Okay.
Came out easily. And that is why she carried the pregnancy so long.
Yeah. Correct.
So then, what would be the plan for her next pregnancy?
Ma'am, she should be counseled well for the next pregnancy
Removal
that
for,
she can
removal of
have
septum.
preterm birth next time.
Do you
Hello?
think
There
we
should
should
be a
cut her
gap of
septum before she goes for the next pregnancy?
Septum resection.
Endoscopy should be planned after maybe like whenever she plans to conceive again. So
She has
hysteroscopy
to
and
undergo
septal
hysteroscopic
resection
resection.
if needed.
Resection of, resection of septum.
And before, if this baby survives, then I would advise her to keep spacing between pregnancies. Then get
She
her
is
septate.
38 years old. She is
Yeah.
38 years old.
But that is at least she should have. If the baby survives, then I mean the next pregnancy may not be necessary also, or she will have to first get the septate resection done and then plan in case she wants to. But I think at least she'll have to wait for 6 months or to 9 months following the delivery before she can go for septum resection.
What is the ideal time?
Yeah,
6
that
or
is
9? 6 months or 9 months?
I think 6.
I'm not sure. So
any opinions from anyone? After how many months do you want to do her septum resection? It's been a vaginal delivery.
6 months is okay, ma'am.
Yeah.
6 months is okay. Absolutely fine. The uterus well involutes up to that. We are doing it routinely.
So now the baby stayed in the ICU because the mother wanted the baby in the ICU till the baby completed 9 months. Okay. And at 1800 grams, the baby was discharged, went home, and the baby is quite well. Mother has been counseled that you need to come for a septum dissection once 6 months have gone by. So, is there any role of preterm birth? Bed
Bed
rest
rest.
to
No,
prevent
ma'am,
No.
not at
birth?
all.
No.
We are not going to advise bed
No,
rest
ma'am.
at all. It will further lead to complications like DVT,
Okay.
obesity.
So, other than vaginal progesterone, and today we learned about the pessaries as well. So, we have progesterone, pessaries, and stitch. But none of them will give 100% results.
No, we have to look for the modifiable risk factors like
Okay.
smoking, drugs, nutrition, malnutrition, obesity, diabetes, all those things which we can modify, that we have to look for and treat those things.
Yeah.
So that
Okay.
can prevent preterm labor to some
Yes.
extent.
So
And
now
most important,
we have
when you suspect that the woman is going to have a preterm delivery, we should refer the case in utero, the fetus in utero, to a tertiary center where the proper care of the newborn can be taken. That is also very important. Timely referral to a referral center where the care of the baby can be done. In utero, the uterus is the best transport media for the baby.
okay. So now, I always I do Dr. MC Patel's webinars, for Happy Masterclass. So I ask you all a medical legal question. What are the medical legal risks in preterm birth?
Another thing we missed is the Maxelf, role of Maxelf.
Yeah,
What is
I
the
was
role of
also
Maxelf? What are the
That is giving
medications you
very
want
good
to give?
result. Nowadays, we are routinely giving
for
less than
neuroprotection.
34 weeks, and it is giving good result. That everybody should know also, because many people are not
Neuroprotection.
giving Maxelf.
What is the dose that you want to give of Maxelf?
Maxelf? We are giving 4
Loading
grams
dose, we are
Milligram of
giving
IV
4
and
gram.
1 gram per
and
hour.
then 1 gram per hour.
Yeah.
Okay, maximum 24 hours.
Yes,
Yeah.
when we expect the delivery to occur within 24 hours, in that case, within 24 to 34, if we expect the deliveries to be going within 24 hours, then we can start Maxelf. It has definitely giving good result.
Okay.
I would also like to add, ma'am, about the shots that we have missed. The progesterone shots are a big no now, because it is not proved that it is going to give benefit to each and everyone. So the shots are a big no.
Okay. Okay. So what will you counsel her about her future pregnancies? Means you've even cut the septum. You've cut the septum, but would you worry about?
She can have
Doing
preterm
well.
birth.
She is 38 years old. Next pregnancy.
And now she has the history of preterm birth also. So we have to take it as a concern in next pregnancy. And
That is the
in
most
this
important risk
pregnancy,
factor.
So
I
now,
Searchlite may be
I
done.
would like
If
to
the
give her Searchlite. Yeah.
yeah,
At
Searchlite with
Searchlite
progesterone,
at
both
14
options are
weeks.
there,
Yeah.
and patient is to be counseled for both the options.
okay. So I request all of you with folded hands, please support me to become the chairperson for Drug and Medical Surgical Equipment Committee. The nominations will be in May and the voting will be in August. Thank you. And now I would like to have take-home messages from everyone who is present here. Everyone.
Ma'am, I would like to repeat my message that don't give intramuscular progesterones once in a week that we used to give previously.
Okay. Sidhu,
Transcendental assessment of cervix is very important and has to be done after 18 weeks.
Yes,
Sidhu,
my
sir?
message will be always try to treat and prevent the modifiable risk factors. Nutrition is very important. Our women are very poor in nutrition, which is also one cause of preterm labor. So as far as possible, everybody should try to prevent or predict and prevent and treat accordingly and refer timely. So that the even with good NICU, we can make the baby survive 800 gram baby. If we could survive, then it is okay.
27 weeks and
Ah,
27 weeks, 800 grams has gone home.
grams baby survived.
Yeah.
Yeah, yeah.
So
So
we-
now my message would be, we are talking about vaginal progesterone, but our Indian women are very bad at inserting. So I always ask the patient to demonstrate inserting vaginal progesterone at every visit in the hospital and check her hands also, nails especially.
Yes, that is very practical point.
Very
Because
practical.
In every
that females
antenatal
stand
visit,
into this infection also.
she's told that day, usually it is done at bedtime. So that day I make her insert the progesterone in front of me, the capsule, in the OPD. So she has to demonstrate to me how she's doing it.
That
And
is a
so
very
sometimes
nice
the
point. Very
apprehension
nice point.
stays. If anything
Yes.
happens, they will blame that the vaginal tablet caused this. So that
TVS first, madam, the TVS, and
Yes.
then the vaginal capsule.
Dr. Archana?
I would like to suggest that we should keep in mind that girls are like they are ignoring the age. Like people are getting married very late, and late age pregnancies are very common. So somehow we should be able to guide them that timely pregnancy is also important, so that we can have gap in two pregnancies also. Once you are to 35, 38, then like it's very difficult. So somehow I feel that this should also be kept in mind somewhere.
timely pregnancy.
Yeah.
About the progesterone, like a lot of ladies have reservations about the vaginal progesterone. So I would like to say that the oral progesterone, that dydrogesterone, is also equally effective and is a good substitute for most of the cases.
I agree.
Yeah, I agree.
Sushant sir, would you like to add something? Sir, you are muted.
Yeah, dydrogesterone is quite helpful and it should be given orally. And actually, nothing we can be doing. If it is going into labor, there is no such thing you can prevent it. So I think the prevention is the better actually. Low cervical length, and that should be considered actually, particularly those who have got the previous history of premature labor actually. Nothing.
Dr. Chelappan? Dr. Chelappan, are you listening? He's there.
Tilappan, I think probably would be from the delegate link.
Okay. So, no, but a delegate link would not be seen here. So these people have joined from faculty link only.
Okay, yeah.
So anybody wants to say anything else? Because this
I
has
would
been
like-
really productive.
Preconception counseling.
Definitely, when you suspect this patient is going to have a preterm delivery, we should admit that patient to the hospital. That is also very important. Let us stay for some time in the hospital and deliver so that we can take care of the baby. That is also very important.
One more thing I would like to emphasize is that we should have these public awareness sessions on preconception counseling. So that at least such septum would have been even.
Yes.
I don't know why in the first three miscarriages, first time I said
It
miscarriages
was not
septum is-
diagnosed. See, it
So
was
that
not
is, that
diagnosed
was one
before.
question
All
which was.
3 scans that she showed me were those chota scans done abdominally, showing misproportion and nothing else. So that is as things actually stand in our place. And Dr. Sujya, you've been listening very hard. So want to add something? You're muted. You're muted.
Ma'am, I'm honestly very happy to see so many panelists in the programs we've done so far. This has been the best attendance. So honestly, they've been very active. So I'm just enjoying the whole
Sujay,
session.
your reminders in the morning also help.
Yeah. Thank you, ma'am. Thank you so much. But it's nice to
It
see all
was
of
really
you.
very nice, and the talks by Dr. Pandana and Dr. Archana is really excellent.
They were ultimate,
Really,
yeah. They
very
were
good.
ultimate.
Both the talks are thanks.
Overall, it was a very good session, ma'am. So we're all happy here.
Yes.
Asha, madam?
Yes.
I would like to add one thing. Most of the times when patient complains of backache, perspiculum examination is very, very important, which many people fail to do. And when we do a perspiculum, many times we see there's a lot of unhealthy discharge, and doing a culture and sensitivity of the high vaginal swab is very important.
I did it. I didn't mention it. And
no,
it
madam,
is
not in this
good.
case. Not
Yeah.
in this case. Like usually what
Otherwise, also in the
Yeah, it should be done. Agreed.
Yeah.
When
And
a
that
patient
helps me a
complains
lot.
of backache, you need to look at the cervix. See, I'm a preventive oncologist. I say always look at the cervix. Always.
Another
Any
thing,
woman comes,
And
keep
ma'am,
an eye at the cervix.
I would also like to stress upon that when you do a speculum examination, we can always do a wet mount preparation of the vaginal sphere and just look for pus cells. Even if the discharge has some pus cells, it indicates a silent infection. Pus cells and clue cells are something which we can always pick up in the OPD itself. And that goes a long way in preventing such complications, an
another
indication
thing,
for
any woman, pregnant woman comes with pain abdomen, they start giving steroids. So steroid abuse is also occurring too much. So that it should be done. You should see the length or dilatation, then only we can start whether it is a diagnosed preterm or it is a threatened preterm. In threatened preterm, we need not give the steroid. So for
Yes.
that, fibronectin may be of help, but it is not available everywhere. So that is the problem.
That
So
is
we
true.
have to
And there is a certain method of taking fibronectin. Means there should be no discharge, no infection, no examination, no TBS. Now, if we have not done all of that, then how will we take fibronectin? And then again, you cannot actually rub on the membranes or anything. So there's a particular technique. And then the transportation and then getting the reports. So it's not easy, at least in our place, it's not easy.
Madam,
because
people
when we decide that we need to take fibronectin, we would have already done an examination.
Yeah, that's what, na? That's what. So I think it's been
Shobha has a
very
question.
excellent. Janmeja
Asha, ma'am, I
sir
think-
has sent me a very nice compliment that he was listening in till now and he has enjoyed it. So thank you, thank you, thank you, my panelists, my speakers, chairpersons, everybody has been so good. So, and we've really done a bullet work and finished our panel in time as well. So you're all free to enjoy your evening. Thanks a lot. We have our Searchlight every week, Wednesday. I will be sending you links, not disturbing you otherwise. So you can share with your societies. Next time we plan to do on postmenopausal bleeding. That will be the panel. So we usually plan one obstetrics and one gynae. I request all of you to join in and not get irritated by the links that I send you. Thanks a lot. Thank you.
The links are
Thank you
welcome,
so
and
much.
ma'am, best of luck.
Welcome, ma'am. Actually, nobody's irritated. It was such a live and academic session. I couldn't also leave. So we are actually enjoying the interaction. Do send the link, and menopause bleeding is such a subject that we should always rope in and try to save the uterus rather sometimes. Thank you, ma'am, for involving all of us. And humble appeal to vote and support both of us. We are here for you. Thank you so much.
Dr. Archana, you are contesting.